Thank you. Delegate Kelly, you can begin.
Thank you. Hello, everybody, and welcome to the Health, Occupations, and Long-Term Care Subcommittee. This is a virtual subcommittee meeting, so I ask for your patience if we encounter any technological or streaming issues. Before we begin, I remind subcommittee members that this briefing is being streamed on the Maryland General Assembly's YouTube channel. Subcommittee members will be muted throughout the briefing. If you have a question after each presentation, type "question" in all capital letters into the chat box on the right side of your window. I'll call on delegates to ask questions. After I call your name, please wait a moment while Dylan unmutes your screen. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from individual panelists. Also, please keep your questions shorter than the expected answer. Today, the Health, Occupations, and Long-Term Care Subcommittee will hear from a variety of agencies and organizations about the current state of hospice care in Maryland. We will also receive follow-up information from the August 26th HGO briefing about COVID-19's impact on our nursing homes and assisted living facilities. In our first panel, we'll hear from the Maryland Department of Health. The panelists include Secretary Robert Neal and Chief Operating Officer Dennis Schrader. This presentation will be followed by a question and answer session. Our second panel will include representatives from the nursing home and assisted living industry. We'll hear from Dana Kaufman of Schwartz, Metz & Wise, Joe DeMatos, the President and CEO of the Health Facilities Association of Maryland, and Lou Grimmel of Lorien Health Systems. This presentation will also be followed by a Q&A session. Finally, we will hear about the impact of COVID-19 on hospice providers. This panel will include Peggy Funk, the Executive Director of the Hospice and Palliative Care Network of Maryland. This presentation will also be followed by a Q&A session. Please keep in mind this briefing is scheduled to conclude by 4 p.m. Our first panel is Secretary Neal and Mr. Schrader, so when you're prepared, you may begin.
Are we on? Yep. Oh, good. Madam Chairman, members of the subcommittee, my name is Robert Neal. I'm Secretary of Health. Thank you for this opportunity to update you. On October 1st, Maryland adopted less restrictive federal guidelines for staff testing and facility visitation. Each nursing home and assisted living program is responsible for ensuring the safety of its staff and residents by using available rapid point of care and PCR testing. Nursing homes have received nearly $10 billion in federal funds nationwide to protect their residents from COVID. Our estimates are that Maryland has received over $120 million in nursing home provider relief funding. Maryland has provided technical and financial assistance, including almost $43 million in testing. That's our preliminary cost estimate. We've supplied over $70 million in personal protective equipment, and we've ensured that every nursing home has at least one rapid point of care test platform and access to the test resupply through our multi-state compact and also Becton Dickinson. I want to turn to Dennis Schrader now, who will give the next phase of the presentation.
Thank you, Mr. Secretary. So on the next slide, if I may, 3, some of the federal actions that we've been working with the nursing homes started back in May, when they recommended that the baseline for nursing homes be to continue testing weekly. And subsequent to that, as the Secretary mentioned, there were 2 rounds of federal funding to the nursing homes, about $4.9 billion in June and about $5 billion in the fall, in August. And then again in August, CMS and the federal administration announced new actions, which included testing twice a week or weekly or monthly, depending on the local positivity factors, and continuing to require the nursing homes to test residents. Next slide, please. So MDH has continued to strongly recommend weekly staff testing, and some nursing homes are doing that, but it is their discretion based on the local conditions The requirement is twice a week if the positivity is greater than 10%, once a week if it's 5 to 10, and then once a month if it's less than 5. Now, for at least the summer and well into the fall, we've experienced less than 5% positivity across the state. But in the last 2 or 3 weeks, we're now starting to see the positivity climb, and we're monitoring the implications of that for the nursing home industry. There were also follow-ups from CMS visitation requirements. We loosened up the requirements. There was a lot of concern about not having access to family members. So as you can see, we put in place some actions that did make it easier without completely opening up the door. And then in October, we had a recent nursing home order that requires nursing homes to maintain an adequate PPE supply. And when we did that, we also sent letters to local officials all around the state, encouraging them to buy PPE to stockpile it with their CARES money so that we get highest and best use of the money that they had left. And there was a fair amount of it, so we did urge them to consider buying PPE. And in addition to that, for the last couple of months, DGS and MDOT have been working with us to put in place a PPE contract series so that PPE could be bought by the locals with state contracts, and that's now being put in place. So quite a bit of activity out of that. Next slide, please. So just this week, we've had additional orders and guidance. As the number of cases and the positivity rate has been climbing and the hospitalizations have been climbing, we've been working with the local jurisdictions and the hospitals throughout the state on their capacity, and we've put some in place, just yesterday it was announced, put in place requirements for additional bed capacity to implement hospital disaster plans. And MIMS, Dr. Delbridge and his team are operationally active on a daily basis in tracking bed capacity, our goal to make sure that we're able to rationalize beds across the state. In addition, in that order, the Secretary put in that when a nursing home outbreak occurs, the nursing home shall coordinate with hospitals for infection control. We've got teams that have been going around the nursing homes. The one thing that we've been told is there is an acute shortage of certified infection control folks available to the state as well as the nursing homes. So we have ordered that the hospitals will support the nursing home in this endeavor. Obviously, we got to work out the details of how that's going to work. We had a call as early as late, as this morning at 7:30 with the hospital industry to talk to them about providing those resources to the nursing homes. And of course, that's in their interest, we believe, because if we're able to contain the nursing home infection control, that preempts having patients going to the hospitals. And then we also put out some more nursing home guidance to Marylanders getting tested and minimizing contact with large gatherings. One of the things we're hearing about is COVID fatigue, where you got staff members innocently going out to birthday parties together or after hours activities, and then they come back in, and they're just it's not something that's done with malintent. It's just people are tired and they're getting a little fatigued by this process. So we're trying to remind people that we have to remain vigilant. Next slide, please. Thank you. So just to give you a sense of the outbreaks since the last time we were together, the nursing homes, there were 90 in assisted living on August 26th. That dropped during the month of October, but now during this latest surge, we're seeing an uptick, and we're looking carefully at how we might intervene. And if I could get the next slide. We've got an analysis of the first wave, where we had 56% of positive residents admitted to the hospital. 92% of those hospitalized died, which is incredibly serious, and 51% of all positive residents died. We had a wavelet in July and August, a smaller one affecting mostly younger people. You can see the numbers dropped. 30% of the positive residents were admitted to the hospital. 68%, about a one-third drop, died, and 21% of all positive residents died. We're now into the third wave. Our data suggests it's starting to affect the older population again, and we're going to be paying very close attention to these numbers. Next slide, please. Some sobering information about deaths. We have 4,100 so far in Maryland, and as you can see, nursing homes, assisted living, and other congregate facilities make up more than half. So this is a major focus for the department in our efforts. Next slide, please. So general, this says testing assistance, but it's more general. It's not just testing. There's other things that we've been doing. Governor Hogan announced an additional $6 million of state-funded testing, 2 rounds of nursing home testing in November. And in addition, we have established technical assistance teams on the prevention side, and we're going around to all the nursing homes and assisted living facilities. We're beefing up our infectious disease outbreak teams after an outbreak is reported. And then we also refer to the Office of Healthcare Quality to do more in-depth compliance when it merits that. Next slide, please. So this is we've noticed that in our technical assistance teams, about 115 of the 226 nursing homes are reporting more than a 15-day supply of required PPE, and we have sent a requirement through order that the nursing homes have established at least a 30-day supply of PPE by the end of November and a 60-day supply by the end of January. The technical assistance teams have visited about 261 facilities since mid-September, and they've referred 34 facilities with significant infection control concerns. And then the outbreak teams have completed 33 facilities with expanded outbreaks. Next slide, please. OHCQ, Office of Healthcare Quality, has been very active. They've completed 415 on-site surveys since March, and with a focus on infection control in 261 of them, and they've imposed 62 state civil money penalties on nursing homes in that period. And so and then there's been some modest increase in nursing home capacity that they've approved. The next slide, please, and I'll turn it back to Secretary Neal, sir.
Mr. Secretary, we're unable to get your audio. I think you're connected by phone and you have to turn on your
I apologize. Each nursing home and assisted living program must take all steps to protect their residents and staff, prevent hospitalizations and hospital surge by early and aggressive infection control. Maryland will continue to work with manufacturers to ensure nursing home access to rapid point-of-care testing supplies and require all nursing homes to maintain PCR lab testing contracts. We will continue our technical assistance teams to outreach to help facilities through the fall, and continued planning to ensure rapid deployment of potential vaccine by pharmacies to nursing homes. The last 2 points are really important. We're going to have vaccine shortly in some small amounts. We've submitted a plan to the federal government to show how we would deploy it as it comes in, and it is going to be one of the largest logistical challenges the health department has faced, because the stuff has to be super refrigerated, it has to be used quickly, and last of all, most of the vaccines being developed require 2 shots. So it would be hard enough to get everybody shot once, but they got to get shot the second time within 3 weeks. So that's going to be a challenge for us. So the nursing homes have really their own pipeline with the chain drugstores, courtesy of the federal government. So we're going to have to keep a close eye on that too, because those vaccinations will be very, very important to us. Thank you for the opportunity to comment.
Wonderful. Well, I think that we're opening up to questions. Do we have questions from the committee? I don't see any hands raised. I'm sure we have questions from the committee.
In the chat box, Delegate Kelly.
I'm looking in the chat box. I'm not seeing anything. I'm not sure why. Why don't you tell me who has their hand raised? Everyone.
It doesn't look like we
Oh,
have
there we go. I have a question from Delegate Bandari. That showed up in my chat box. Delegate Bandari.
Oh, I'm sorry. Yeah. Thank you, Secretary Neal, for a wonderful presentation. I'm wondering if the data on outbreaks and cases among facilities can be broken down by district.
We've never done it that way, but I think we probably could. You're talking about legislative district. Would probably be easier to do it by zip code, wouldn't it, Dennis? Yeah. Would zip code make sense? Would that work?
Yes, it does, but it would be wonderful if it would be by legislative. But you're right, some of the our district overlap different zip codes, so.
I think we could get that information to you quicker if we could do it by zip code or location other than a legislative district, because we'd have to overlay that on the district map. And I still think there'll be some idiosyncrasies if we did it that way.
Thank you.
Yes, sir.
Great. So we have a question from Delegate Cullison and then a question from Delegate Bagnall. Delegate Cullison.
Thank you, Madam Chair, and thank you, Mr. Secretary. And I'm working through the technology here. Good. I heard throughout the presentation your concern about spread of the virus and how contagious it is and how we have to keep everyone safe. In that light, I'm very concerned about the provision that requires nursing homes to share staff when they lose staff because of the virus. And it seems to me that this is inviting spread across nursing homes. And so I'm wondering, first of all, what's the rationale? How do you, and aren't you concerned about the additional spread? And if nursing homes aren't able to do it, if they're not able to share either because they haven't been able to work with another facility, or someone is a staff member doesn't want to go to a site where there's known cases of COVID, what is the state going to do? And are there going to be penalties for this?
So, Delegate, thank you for that question. The issue at the moment is that we have had a handful of nursing homes that failed, and we had to come in very rapidly. this is a preparedness activity. We're not dictating how to do it, but we think it would be prudent for nursing homes to prepare ahead of time on how they would handle a problem. We've suggested mutual aid as one technique, and we've had discussions. Our understanding with the industry is about 80% of the nursing homes are in one system or another, or have multiple ownership, and about 20% do not. So in the 20%, obviously, we're looking at a way of intervening ourselves. But for those that have multiple nursing homes in a system, we'd like to see them figure out how to do mutual aid.
Madam Chair, may I?
Please do.
Okay, so I'm not getting penalties or the consequences of not doing it, number one. But number two, wouldn't it work to have the facilities themselves figure out and perhaps give you a plan as opposed to requiring this mutual aid arrangement?
And I mean, that's what we're asking them to do. We'd like them to give us their plan on how they're going to do that.
So then there wouldn't be any, this is just a suggestion and there's no requirement or penalty for not doing the mutual aid arrangement.
Yeah, well, we had asked for it and it wasn't done, so now we've done an order and there is penalties, but that's not our purpose for this. Our purpose is to encourage the nursing homes to do this because we think it's really important. We had a recent event in Caroline County. We had the problem in Carroll County, and when they collapse, we end up having to come in and on a rush basis. We really think from a preparedness perspective, this is important. So we asked nicely the first time. Now the Secretary has ordered it. So we're hoping that we can see some action. But it's not intended to be punitive. That's not the idea.
So just one more, Madam Chair, and I promise I'll stop.
I think you're onto an important issue, so please do.
I'm still worried about the spread. I mean, what you're literally asking the nursing homes to do is to send their staff into a facility where there is known infection.
Testing.
Yeah, go ahead, Bud. Go ahead. Go ahead.
Yep, it's
yeah, go ahead.
But we're gonna require testing anyway, so we're gonna make sure that we don't make a bad situation worse. Right. And with the what do we call the teams that we use during the summer?
Technical assistance.
The technical assistance teams.
Right.
Those people were all tested. We wouldn't send infected people into a situation that's already problematic.
I think I would suggest this needs some more consideration, and I'm worried that nursing homes are going to be put in a challenging situation, and they ought to be given the opportunity to come up with a plan that meets the requirements that meets the staffing requirements that we can set. So, Madam Chair, I'll turn it back over to you. Thank you very much for your indulgence.
Absolutely, Delegate Paulson. We have 3 more questions. We'll hear from Delegate Bagnell, then Delegate Johnson, then Delegate Kerr. Delegate Bagnell.
Thank you, Madam Chair, and thank you for the presentation today. I just wanted to follow up sort of on the lessons learned from the spring, because I know that we're trying to put things in place, but there were 2 major problems that I want to see how we're addressing. One was the fact that we didn't have inspectors going into the facilities ahead of time, so we weren't finding out about some of these the infections and spread until it was a rather dire circumstance. And the other is that given that we're seeing a rise not just in the state of Maryland but across the country, do you foresee an issue with the acquisition of PPE? Because if we're asking these facilities to have 15 days to 30 days out, will that PPE be available, and how are the facilities, how are we working with the facilities to make sure that they can acquire it?
Yeah, thank you for that question. On the inspection side of it, we established over the summer technical assistance teams, and we're on a 60-day cycle to go through all nursing homes and assisted living facilities. We've been through one cycle. We've just started the second cycle, and we're looking at infection control, testing, PPE levels. So that is ongoing, because we agree with you. That's an important prevention measure. And we're doing it without being punitive again. We're just trying to encourage people to do the right thing. If we find something that gives us pause, we will follow up on it, but the intent is to really be helpful to the nursing homes. And your second question, I'm sorry,
PPE.
the PPE is that we are encouraging them to use their money that they've received, but we're also encouraging the local jurisdictions to beef up their PPE stockpile with the CARES money that they have. We've sent significant money to local jurisdictions. It hasn't all been spent, and we've put contracts in place at the state level so that they can order, the local jurisdictions can order off those contracts. So we're going down this on two tracks.
Thank you, Madam Chair.
Absolutely. Let's hear the question from Chairman Pendergrass before we go back to Delegate Johnson and Delegate Kerr. I'm sure you won't mind. Madam Chairman, you have a question?
I do. Can you hear me?
Yes.
Good. Thank you. So I'm concerned about a number of things. First thing I'm concerned about is that it's my understanding in the paper today, I believe that we have a 30% at the federal level. Is it 30 days or 30% of what we should have of backup of PPE for the country? So can you tell me what we have as backup PPE in the state of Maryland that we're holding in case we need it?
Yeah, Madam Chair, we've been tracking that. We started quite a while ago. For most of the large requirements for gowns and masks, et cetera, we have at least a 45-day supply, in many cases 60-day supply at the state level. And we have a steering committee with the hospitals, and the hospitals have been driving towards a 60-day supply. So we're feeling better than when we were in the spring. We're not overconfident, but there's been a lot of work done in building PPE stockpiles.
I'm glad to hear that. I am concerned because I think we all believe that this is going to crest in January, February, and we're not there yet. And this does not necessarily get us through that period, and it may not have taken into account the magnitude of the crest that we're going to see. That's number one. So please keep it up. Apparently the country is in a free-for-all for getting PPE right now. So it's going to be harder and harder for anybody smaller than a state to do it. Second of all, I'm very concerned, particularly having heard your answer, Dennis, to the question about nursing homes, because you didn't get enough of an answer from them. And when did you ask for the original answer about their staffing backup plans? Can you tell me the time frame of that?
It's been throughout the summer on a number of occasions.
Okay, well, that's somewhat helpful.
Yeah.
I would hope that they would try to come up with answers, but when you say you've put in penalties, do I recall it's $5,000 maybe a day, or is it an event, or what? Is the non-punitive punishment for not having a backup plan? Can you clarify that?
Yeah, it's up to $5,000 for a year, but that, again, the penalties are not intended to be punitive. What we really want is the plans in place, quite frankly.
Well, it's very difficult for a person, for instance, if I tell my children, which I have done, if you don't start improving your behavior, I'm putting you out of the car to walk the rest of the way home. Frankly, when I say that to my children, I wish I didn't have to be punitive, but I have put them out of the car when they were children. And they did learn from that they had to be a little more pleasant in the car. when you don't put out penalties if you don't plan to enforce them. That doesn't make sense to me. You have to do what you're supposed to do. If you say you're going to do it, you do it. If it's not what you mean to say, then don't say it, please. Beyond that, the concept that you're going to have people going from one facility to another is a terrible idea. I think we proved that early on, that the worst thing we can do is have people in multiple facilities, because then you spread a problem from one facility to another facility. How can you in good conscience be suggesting that as a solution?
Our understanding from the nursing homes is that those that have multiple ownership actually already move people around, and the purpose of the testing is to keep track of within the nursing home companies. We're not suggesting that one company would exchange with another company, but each company is responsible for their own people, and it's our understanding they already move people between facilities.
Well, I would first be suggesting that they don't be moving people from one facility to another, because whether they own it or they don't own it, it becomes contagion or contagious, and it gets spread from facility A to facility B. It's just a very unscientific way to be having a backup plan. But second of all, does your plan actually say only for those companies who have multiple sites, or does it just say all nursing facilities? Who have you asked to have these backup plans that include backups from other facilities?
When we met with the nursing home industry, we asked about how the ownership structure, and our understanding is that, and again, we're not doing the planning for them. We've been asking them the questions, and the questions we've been asking is how many nursing home companies own multiple facilities, and our understanding is that 80% of the homes have multiple ownership, and therefore they can come up with their own plans. We have not been prescriptive in the plans.
So if I say that my plan is that I'm hoping to get people when I need them, you're going to accept that as my plan because you're not prescriptive, and I'm not going to get penalized for submitting that?
No, actually not. We would review their plan to see if it was acceptable, and it will, by looking at the level of detail and the seriousness of the plan, we'll then be able to determine whether it's a reasonable plan.
And have you given them guidelines for what would be in a reasonable plan and what would not? For instance, we do not want your workers moving from one facility to another because that's a worst possible way to deal with these things?
I think the nursing home industry has indicated to us that's their preference, to not move people unless they absolutely have to. That's our understanding.
Have you put guidelines in this request for their plans?
I don't believe we have, but we can.
Have you met with the nursing home?
Yes.
How often have you met with them?
We've had a couple of meetings on this subject, as I said, over the summer and into the fall.
So that's a couple.
So we can get more aggressive. We can be more aggressive. I think we were meeting weekly at one point.
You've said a couple meetings over the summer and fall. That implies 2 meetings in 6 months. Is that accurate?
No, I don't think so.
Then I'm confused.
Yeah.
Can you clarify?
I'll tell you, Madam Chair, why don't I go back? We have a record of all the meetings. We'll get a listing so that we can get them to you.
We have a history of a track record that the health department has had, often that you propose things and we don't see the good faith working together with stakeholders that we would like to see. This is not just about nursing homes. This is historic, whether it's mental health providers I'm thinking of in particular at the moment, but it's all kinds of providers. I would like to see some evidence that you have actually been working with the nursing homes and that you have a plan to continue collaboratively working with them and all the stakeholders.
We'll get that to you right away.
Thank you. Thank you, Madam Chair, for allowing me to ask my questions.
Absolutely. Thank you. And thank you, Delegate Johnson, for your patience. Your question's up next.
Thank you, Madam Chair, and thank you, Department, for coming and giving us this presentation today. Since we're talking about moving staff around between nursing homes and backup plans, I see the information we have on residents for cases of COVID and deaths. Do we have any information on the staffing that works these nursing homes and these assisted living facilities, on the number of cases that the workers have contracted COVID or deaths?
So we have their testing data up through August, and we can make an inquiry and get some more data for you on that, but there is data.
Okay, I think that would be a helpful tool in as we're talking about moving staff from facility to facility. So if we could get that, I would appreciate it. Thank you.
Absolutely.
Delegate Kerr, your question?
Thank you, Madam Chair. Mr. Secretary, does the Office of Healthcare Quality have the resources it needs, or will it have the resources it needs to monitor all these challenges as we enter this third wave and as we anticipate continuing challenges in the January-February timeframe?
We're keeping track of all that. Dr. Ney is consulted on a frequent basis about what her needs are, and we will have to staff up to whatever the demand is on that kind of work.
So they will have adequate resources to do their jobs.
I will do everything I can to make sure that they have adequate resources to do their job.
Thank you. Thank you, Madam Chair.
Absolutely. Any more questions from members of the committee? I don't see any more hands raised. I had one brief question. The secretary mentioned that there's a possibility we're looking at a 2-dose vaccine and that administering that becomes more difficult. And I just wanted an update on the status of Immunet. I know that we have been working to expand providers participating in Immunet, and I know that that's the foundation for our vaccine distribution plan. So I just wanted to know if you feel comfortable that Immunet is going to be ready to handle these challenges of a 2-dose vaccine.
I feel confident that we'll be ready. We're trying to synthesize about 7 different sources, but our technical people tell me it can be done, and they're working on it. So Immunet's going to be an integral part of the success of keeping track of all this activity, and we need to be right. So we're going to get there.
Great, thank you very much. And thank you all for your patience and your answers to our questions. I don't see any more questions for this panel from the committee. So let's move on to the next panel, which is the nursing home and assisted living industry. Dana Kaufman, Joe D'Amatos, and Lou Grimmel. I think Dana Kaufman is going first.
Yes, thank you very much, Chair Kelly and members of the committee. For the record, my name is Dana Kaufman. I'm with the law firm of Schwartz, Metz & Wise, and I'm here on behalf of Lifespan Network. And Mr. D'Amatos and I had decided earlier on that we would basically divide up our presentation so that we did not duplicate efforts. And in addition to Lifespan and HFAM working together, I also do want to mention that we have also been working collectively with Leading Age Maryland. So the 5 areas that we're going to discuss today are basically PPE, visitation, workforce development, testing, and then vaccination. And I'm going to handle the first 3. The first thing, though, that I want to say just at the onset is that we are now seeing a rise in positive cases. We are seeing additional community spread. Unfortunately, nursing facilities, assisted livings, we do not live in a bubble. We are not the NBA. Our residents work in, our staff work in the facilities and they live in the community. So unfortunately, we are going to see increased cases in the nursing facilities, and our staff, they are working 24/7 to ensure the safety of residents during the last 9 months, and they're going to continue to do that throughout this pandemic. But when there is a case, that does not mean that they failed in their infection control. If that's the case, then everyone in the country has failed in their infection control. And I don't think that that is the case. This has been called a very sneaky virus. and we are doing our best. And for our staff, it's a Herculean effort. So I think at this point, moving forward, as we go through this wave, and hopefully it'll be our last wave with the therapies and the vaccines on, we are asking for your continued support for not only our residents, but for the staff that have worked so hard every day for 24/7. So I just wanted to make that point. And now to go in through a couple of the items just to talk about. So PPE, we are right now, the nursing facilities are facing two deadlines, the 30-day supply of PPE by November 30th and the 60-day supply by January 31st. Right now, the order does say that the supply does not have to be on site, but reasonably accessible. Lifespan, in partnership with HFAM and Leading Age Maryland, since the beginning of this pandemic, has worked very hard to assist healthcare providers in purchasing that PPE. And for us, one of the benefits is if we can buy in bulk, then we can distribute it out at a much lower cost than each individual facility being able to purchase it themselves. One of the things that we are doing right now is that we have contracted with a storage facility to allow providers who order it to be able to store it. The providers will have access 24/7 to the storage facility. This is really important because facilities just don't have the physical space for 60 days of PPE. This is not, one mask, one pair of gloves per worker. This is an enormous amount of PPE. So we have been and will continue to work with them to ensure that they can meet this requirement as well as the storage. What we're finding right now is that the PPE that is in short supply are face masks, face shields, and gowns. Those are the ones that they have the less supply on hand. So we're working diligently to provide those orders and to get those out to our residents, or to our facilities for our residents and staff. The other issue I wanted to talk about right now is the visitation. It was already mentioned that on October 1st, the state did adopt the CMS guidelines for indoor visitation. So right now, outdoor visitation on nice days can still occur, but we do have indoor visitation. That indoor visitation is put on hold for at least 14 days when there is an outbreak, or when there is then the following testing of all staff and residents. During that time period, outdoor visitation, weather permitting, can still occur. There has been questions raised because in the order that went out on Tuesday, it does say that Marylanders should take all precautions to protect their loved ones at nursing homes and assisted living programs, including staying home if sick and getting tested before they visit. The order that CMS, or the guidelines put out by CMS, also encourages but does not mandate that visitors get tested. So that is really becoming the policy that the nursing facilities and assisted livings can decide. But I do want to mention that neither CMS or MDH have stated what happens if a visitor refuses. Again, it's an encouragement, it's not a mandate, and it's unclear right now what the nursing facilities can and can't do if they wanted to require testing and somebody did not want to be tested. But it's also important to note on that point that CMS has said that facilities may not restrict visitation without a reasonable clinical or safety cause. And one of the examples that they gave is if a facility has had no COVID cases in the last 14 days and its positivity rate in their county is low or medium, a nursing facility must facilitate in-person visitation. So I wanted to mention that because we're already getting questions from our members about the visitor testing and what was relayed by the order and in the governor's press conference. For visitation, that was just the one point that I really wanted to make. In addition, the visitation does allow us to the facilities to implement additional restrictions. This really goes down to the number of individuals allowed in the facility or facility specific times or where they can have the visitation. But again, we also always want to be sure that we're giving the appropriate privacy to the family members and the residents. The last issue that I'm going to address really is this workforce issue, which really has been the subject of many of the questions. And workforce development is probably one of the most important areas that we are facing right now, and that I think we are going to be facing for the next year or two. As everybody has always heard, me and others have said, there before the pandemic was a shortage of direct care workers. The pandemic has made that much worse and trying to find staff. What I would be asking is that the state, and this goes to Maryland Department of Health, but also Maryland Department of Labor, Board of Nursing, we really need to develop new and innovative ways to bring staff into the long-term care arena. One of the things that we have been saying is, unfortunately, there are many individuals who have lost their jobs and whose jobs won't be there for them to come back. And we need to find ways to be able to transition them into other fields. I know that Lifespan has been having conversations with the Maryland Board of Nursing and the Department of Health on a new online CNA, GNA training program. I think just this morning we sent some additional information for their consideration to the Board of Nursing. We are ready to go on that, and we are hoping that we can get approval and get that up and running by the end of the year. Again, that is, we can say we need staff, but there has to be a bucket of staff for us to go to. So that is one of those issues that I think we're going to just continue to be hearing about, that this pandemic has really put additional pressure on the industry, the healthcare industry as a whole. So those are the 3 points that I wanted to make. I'm going to turn it over to Mr. D'Amatos to talk about testing and vaccination right now. Thank you.
Thank you, Donna. Madam Chair, may I proceed?
Absolutely, please do.
Thanks, my friend. And thank you all for being here and the leadership that you're providing for this critical time as we face this pandemic. We really appreciate it. I like to put a face to the numbers and offer some context. I do want to speak about testing, vaccination, and workforce, and I do want to respond to some of the questions and exchanges earlier. I will tell you that we're proud of our partnership with Leading Age and Lifespan in Maryland and with the American Healthcare Association nationally. We have a 4 o'clock call today with CMS and Seema Verma on the vaccine, just to let you know. And I want to say that HFAM issued our first alert on the pandemic on January 29th. And we've been working long hours since then to support the frontline workers. So if you look behind me, Madam Chair, that picture right there is at a nursing home in Montgomery County.
Yes.
And those are actually the healthcare heroes that we're really talking about today when we talk about all of these issues of policies and numbers. So I just wanted to revisit some of the numbers for you all and put some things in context. These are real numbers. These are actual numbers. So as you all know, we have 227 skilled nursing and rehab centers in Maryland. We have had tragic deaths in nursing homes, in hospitals, and across the state, just as we have across the country. And every death is to be mourned, and every life saved is to be celebrated. But I think we're looking at the wrong numbers, and it's frustrating sometimes to look at the wrong numbers. So the next number I will share with you is a real number from the Maryland cost reports. From January to September this year, across all payer sources, the skilled nursing and rehab centers in Maryland have provided 5.8 million days of care to Marylanders in need. 5.8 million days of care. That's a fact. And so when you compare the death rate of people that have died in nursing homes or at hospitals going for intensive care from nursing homes, sadly, that death rate is equal to the death rate outside of nursing homes for people who are older or who have pre-existing conditions. So again, while every single death is to be mourned and every life to be celebrated, it is a fact that we have provided 5.8 million days of care to Maryland in need during this time, and the vast majority of people have survived and beaten the pandemic. Let's talk a little bit about the state bridge teams. The state bridge teams in the heart of the first surge, March and April, were a godsend. You know, when Kevin Hefner and I met with Governor Hogan on March 12th, we told them it was going to get rugged. We told them that people were going to die. And we told him that based on the experience in Kirkland, Washington, there was not enough cavalry to come to the aid. And that happened for us, along with most of the rest of the country, in March and in April. So those state bridge teams, again, we have 227 skilled nursing and rehab centers in Maryland, deployed less than 20 times. All right, just to put things in perspective, we didn't have 227 skilled nursing and rehab centers who couldn't get the job done. We received state bridge teams, thankfully, as sent by God, saving lives less than 20 times. All right. In the time since then, we have had bridge teams less than 5 times in the state of Maryland, just to put that in perspective. Now, relative to the funding of care, Secretary Neal is exactly right. The 15,000 skilled nursing and rehab centers in the United States, who care for about 1 million people in the United States, have received about $10 billion in CARES Act funding. About $10 billion nationwide to 15,000 skilled nursing and rehab centers. In Maryland, we estimate that the range of those CARES Act dollars are between $600,000 and $800,000 per center total for all the tranches. There'll be outliers on either side. Obviously, Madam Chair, the largest skilled nursing rehab center in Maryland is Charles E. Smith. They would have received substantially more than that. But the average in Maryland, probably between $600,000 and $800,000 in CARES Act funding that must be used in the pandemic. Just last week, the nursing homes received the first value-based payment in Maryland for reducing the number of cases and deaths in September when compared to previous months. The average payment to a nursing home in Maryland on that value-based payment to reduce deaths was less than $20,000. Again, these are real numbers, right? So let's go back to the really big number and tie that up for a second. And then we'll go to testing and the vaccine and to workforce. So nursing homes across the country have received $10 billion from the federal government specifically to be used for care, $600,000 to $800,000 to each nursing home in Maryland. And the state of Maryland government, in contrast to that $10 billion nationally to nursing homes, have received something between $3.8 and $5 billion in CARES Act funds. The state government of Maryland has. So I'll just pause on that and let that sink in. Relative to testing, the governor rightfully loosened up testing, and based on our advice and many other jurisdictions, linked testing in the orders in October to the relevance, the positivity rate, and the case per 100,000 in the community. So that was accurately covered by Secretary or Chief Operating Officer Schrader. So just put things in perspective, if you were to look at Montgomery County on October 1st, in Montgomery County, the positivity rate was 2.83%. 2.83%. And on October 1st, in a typical Montgomery County nursing home, the positivity rate among staff would be about 0.35%. 0.35. I hope you're following me. In October, in Montgomery County, on the 1st, the actual positivity rate was 2.83%. In an average sized nursing home, the staff positivity rate was about 0.35. And for residents at the time, it was also less than 1%, probably in the 0.8 to 0.96 range, right? As of now, the positivity rate in Montgomery County is closer to 6%, 5.6%. And we would expect, based on previous sort of experience, that the testing rate for staff, the positivity rate for staff would probably be between 2 and 3%. And depending again on the acuity of the patients and how big the nursing home, maybe from 2 or 5% on testing. So as we are fighting this co-occurring surge of the seasonal flu and COVID-19, as we predicted months ago, we will see community positivity rates go up, and we will see positivity rates, as Dana pointed out, in skilled nursing rehab centers, assisted livings, and in other businesses also go up. And that's more the case in healthcare, not just in nursing homes, but at hospitals, because our workers come and go and they can't just stay home. The ones that are sick, test positive, or exposed should absolutely and are staying home. But you can't shut down a hospital, a nursing home, and assisted living. On the vaccine, there were 7 national companies that were giving billions of dollars by the federal government to develop vaccines. We all read that Pfizer is at the front of that pack. Secretary Schrader covered that very effectively, and as did Secretary Neal, that the Pfizer vaccine is a 2-dose vaccine that has to be kept and transported at 90 degrees Fahrenheit below zero, and it's going to be challenging to do that. It looks like the Moderna vaccine, which has to be transported more at 30 degrees Fahrenheit below zero and is 1 dose, is probably right behind the Pfizer vaccine. The federal government created a partnership with Walgreens and CVS, where they will distribute the vaccine to nursing home staff and residents who sign up. The first deadline for that was to sign up was November 6th. And we have a top priority from the federal government, nursing homes and assisted livings, for that virus, for the vaccine, to get the vaccine. The state of Maryland will also distribute allotments of the vaccine, and I can answer any questions that you might have about the vaccine or the current flu season. One very last point, relative to the exchange of Delegate Cullison, Delegate Pendergrass, and with Secretary Schrader and Chief Operating Officer Schrader. It's a little frustrating. The exchange is a little frustrating, and I'll tell you why. We've had one in-person meeting with the Department of Health on this issue of staff bridging. We've probably had a handful of calls. That one in-person meeting was very productive. The calls have been very productive. Let us be clear. The industry has been working actively since before the ban on visitation, since before we knew that COVID was asymptomatically transmitted, to prevent and avoid folks from working from one center to the other, And we advised the state of that in all of our meetings. On September 25th, I emailed that group on behalf of all the associations, all 3 associations, giving them an 80-20 list of the 80% of the sector that we thought would be okay, the 20% that we thought would be problematic or would need help. And we pushed back on this issue of mutual aid. So it's frustrating to hear that we didn't come up with a plan, that we didn't have feedback when I personally emailed back the state on September 25th. I'll leave it at that.
Thank you. And we have also to hear from Lou Grimmel with Lorien Health Systems, and then we will open up for questions.
Thank you. I have nothing further to add from Dana's presentation and Joe's presentation. But I'm available for questions.
Wonderful. Well, it's wonderful to see you here. And we do have a question from Delegate Johnson.
Thank you, Madam Chairman. And thank you for the presentation. Mr. D'Amatos, will Maryland follow the federal priority list when we get the vaccine of going to our nursing homes and assisted living facilities for the residents and the staff workers?
Yes, I anticipate that the majority of skilled nursing and rehab centers and assisted livings will sign up for the federal partnership, and we're incredibly thankful for that federal partnership. I still remain concerned about independent living communities and the other organizations that will draw upon the Maryland state allotment. But yes, I believe that the majority of skilled nursing and rehab centers will sign up, will participate in the federal CVS Walgreens plan. It will be complicated, but it'll be a godsend. It'll be a game changer, and it'll take time, but it'll be very important.
And one more question, if I may, Madam Chair.
Absolutely.
In that plan, does it have the residents going to the pharmacy chains or those folks going to the nursing homes and assisted living facilities?
Great question. In our behind the scenes work with the American Healthcare Association, CMS and CDC, it was mapped out that between CVS and Walgreens, they are about no more than 75 to 100 miles away from every nursing home in the United States. So with the help of the US military and the National Guard, CVS and Walgreens are planning to go to nursing homes.
Okay, thank you very much.
Next question is from Delegate Bandari.
Yeah, thank you, Madam Chair, and thank you, Dana Kaufman and Joseph D'Amatos for a wonderful presentation. We are still in the midst of the pandemic, and our positivity rate is increasing. Once again, this is particularly worrisome as we move into the winter months where things are expected to get worse. Needless to say that our nursing homes are going through the hard time. Secretary Neal mentioned in his presentation that Office of Healthcare Quality Activities imposed 62 state civil money penalties on nursing homes. The lack of internal effective communication among these facilities were highlighted by Chairwoman Pendergraft, which seems like a reality here. We'd like to hear the perspective of healthcare facilities. How are those facilities feeling about these civil penalties? Are they considering it as a punitive measure? Were they given enough opportunity to comply? Or what do you think the state has to do more?
If I might take that question too.
Sure.
Just to put it in a little bit of perspective too, the 62 that received civil money penalties, they were not all related to what I would call direct patient care. Over half of those were related to issues involving reporting requirements and testing. And when I say reporting requirements, that was a $250 fine for either not reporting or late reporting to CRIS. So earlier on in the pandemic, the state required a multitude of issues to be reported to Chris on a daily basis by 10 o'clock. And unfortunately, it took a little bit of time for that process to really gel with the nursing facilities. Like, for example, I know a facility who received a $250 fine. He thought he had submitted his data. Unfortunately, at that point, receipts weren't given back. So for whatever reason, his data hadn't been transmitted to Chris, and he received a $250 fine. Later, when we were working through this process, receipts, Chris was able to generate a receipt. So that helped facilities know that they had accurately reported that information. There were also reports or fines given because in order to do the testing that the state was doing during the summer, you had to submit a roster. And at times, because of the fluidity of the situation, the rosters and who tested didn't exactly match up. Some of the facilities were saying that those staff who had initially been on the roster weren't there during testing. Either they had left or the facility for various reasons, but there were at times fines given. So I think it is important to just recognize that for those civil money penalties, about over half were what I would call the administrative penalties. I think the larger issue, though, is not with the state, but with CMS. The way CMS calculates their penalties, you can have a penalty that is in the six figures for one issue. And that is extremely difficult. You can imagine any type of penalties during this period when revenues are already down and you have penalties being applied. So we always hope that penalties are done judiciously because we don't want to affect patient care by a penalty. That should not be the purpose of that penalty. You want to work with the nursing facilities on corrective plans of action to avoid any issues that they may have with infection control. But penalties, of course, are always going to be problematic, especially in this atmosphere. But I really did just want to emphasize and not have you left with the fact that 62 of those civil money penalties were all infection control or direct care, because they were not.
Thank you.
Next question goes to Delegate Cullison.
Thank you, Madam Chair, and thank you to you all for your work and also for your presentation. Joe, I want to make sure that I understood what you said. You had provided the Secretary Neal and his staff with. I heard you say that you gave them an 80-20 list and that 80% of the facilities would be okay and would be able to manage, if there were staffing issues because of infection, and that there were 20% that you were concerned would not be okay. So first of all, my first question is, am I interpreting that correctly? And the second question is, what was the plan for that 80% to be okay? And did you have any recommendations for a plan for that 20%, even to the extent of saying perhaps the state could extend its bridge team program, anything like that? So I think that's my question. Thanks.
Delegate, thank you so much for your question. Yeah, let me give you some context and background. The genesis for the conversation was that the state indicated that they would not be in a position to provide the bridge teams, those less than 20 engagements that happened in March and April in a fall surge. So the first context of this conversation happening in September was, hey, industry, we will not be in a position to offer the bridging that we did in March and April as we enter the fall surge, and let's put our heads together on what we can do about that. So that was the first context. The second context was, and I need to do one sort of step back here, is that in the time that most of us have been working on these issues, certainly you and I Delegate Cullison, over the last several years, there's been a consolidation of skilled nursing and rehab centers in Maryland. So when I came from AARP to HFAM, we probably had 40 or 50 centers that were part of small family-owned chains or county-owned. Now there's maybe 14 or 15, right? So you have more regional operators, the Communicares of the world, the Future Cares of the world, the Savas of the world, that have 10 to 20 nursing homes. So the second parameter when we were meeting with the state was that the state's expectation was that that part of the sector, which is the majority part of the sector in Maryland, would need to be able to take care of themselves, right? So that was the second parameter. So parameter one is the state's not going to be able to advance bridge teams. Parameter two, the majority of the market's big enough, you should be able to take care of yourself. So based on those parameters, all three associations came together and we had the discussions with the state, and we identified folks that we thought might need bridging in a fall co-occurring pandemic, co-occurring surge, right? So that was the 80-20. And the idea was that the state would actually not be responsible for bridging a whole sector, but maybe 20 centers in the course of an emergency. And then in that, we wrote to the state and pushed back on this concept of competitors, which was very much on the table in discussion, competitors helping one another. We weren't even supporting folks moving from back and forth, much less somebody going from Sava to Genesis to Future Care, right? So that was the basis of the discussion. There have been a lot of learnings, and we certainly haven't been perfect in this, but I tell you what we have been, at least I think I'm sure all three associations have been, is we've been transparent. I have to share one more bit of context from a learning. So when we were in the worst of this in March and April, there was a discussion about, which would have been a really bad medical thing to do because of the people in our care having pre-existing conditions and by definition being medically challenged. There was legitimate discussion behind the scenes about moving hundreds of nursing home patients from nursing homes to hospitals. Had the hospital surge occurred, that would have been catastrophic for hospital capacity. And even if it had not occurred, that would have been catastrophic for the actual patients and residents who live and receive care in nursing homes. So we were actually talking about this stuff behind the scenes. Secretary Schrader and I had some very productive, frank conversations about that, as I did with Dr. Haff. The reason why that's important is at the time the alternative that was developed, especially at UMS, was that UMS deployed teaching RNs to nursing homes to mentor and guide nursing home staff. So one of the organizations that needs to get an award after this is UMS. Because when we were talking about kind of doing crazy stuff in the middle of a pandemic that we had never ever encountered before, stepped up and they sent resource nurses to nursing homes to help. So, by the way, did Hopkins, and then Hopkins actually stood up in doing testing in advance of state testing orders. So there's a lot of these stories. Now, the reason I bring this up in answer to your question, to wrap it up, Delegate Cullison, is this. Bridging, an essential part of bridging going forward, will not be sharing whole lists of staff from nursing home to nursing home, but probably it will involve, in best case scenarios, resource nurses from hospitals helping nursing homes. And one thing that's different now versus then is that we have HSCRC funded grants for those partnerships, and we have a federally funded Echo Hub partnership for those partnerships.
Okay, thank you. Thank you, Madam Chair.
Absolutely. Thank you. The next two questions are from Delegate Bagnell and then Delegate Lewis. Delegate Bagnell.
Thank you, Madam Chair, and thank you for your presentation. I want to go back to the PPE a little bit, because we know that it's expensive to keep people alive and it's an investment we have to make. And one of the challenges from the beginning of this pandemic was keeping local communities flexible. But as Ms. Kaufman pointed out, the financial reality is that buying in bulk is far more fiscally efficable. So how do we avoid what happened in the early part of the pandemic, where it was sort of every district for themselves? How are you able to work with county facilities in accessing some of these funding resources from the CARES Act while you're working to buy in bulk, to store, and to distribute? And do you feel like you have the support you need, or is there something we could be doing to make that part of the process easier and more efficient?
Sure. Would you like me to answer? I wasn't sure if that was for me or the health department.
If you could speak to that from the perspective of the facilities.
Sure. Well, the good news is what I'm hearing is the cost of PPE has come down dramatically from those first couple months where it really was bordering on price gouging, but it was supply and demand. So that's the good news. So the prices are much better now. The issue is becoming availability. In the beginning, facilities could request PPE from the local health departments. Unfortunately, there was just a shortage everywhere, and everybody was competing against themselves, each other, the other states. So I do know that Governor Hogan, I believe, had issued grants for local companies to be able to manufacture PPE. So hopefully that also has continued to help with the supply. I do believe, and the health department, Mr. Schrader may want to also comment on this, that it does seem that from the CARES Act, more money is going from the locals for PPE. So I think as we go forward, we will continue to try to coordinate with the local health departments and emergency management. But at the same time, it's just a reality. Everybody's looking for PPE. I mean, it's not even just the healthcare facilities. You have to have PPE in any business in the state right now. So the volume that is needed now is just like it has never been before. So I think as the associations, we're going to continue to support our members, but not just our members, really anyone who needs it. In doing that bulk purchasing, we have a great organization that we're working with that's located in Owings Mills, and we're going to continue to place orders and hold the PPE for them. But I think it's always going to be an all hands on deck. So when we have the opportunity to continue to work with the locals, we're going to do so, but that doesn't negate what we consider our responsibility as well to go forward with the purchasing.
Thank you. Thank you, Madam Chair.
Absolutely. Delegate Lewis.
Okay. Thank you so much. Thanks for the presentation to Ms. Kaufman and Mr. DeMattos. My earlier question got answered, so I had to think of a new one. And it's about those value-based payments that you mentioned, Mr. DeMattos. Value-based payments based on the reduction of mortality in a given center. And you said that because mortality is declining, in some centers, they've been getting these value-based payments. Could you talk a little bit more about that, just so that to make sure I understand what that means?
No, I appreciate you asking the question. So CMS identified a federal fund of $500 million a month nationwide. So let's just do the math, write it down like the other numbers I shared. So CMS has identified as part of the CARES Act funding and set it aside $500,000 a month for the months of September through December to make value-based payments only to those of the 15,000 skilled nursing and rehab centers in the country that meet a mathematical formula on the reduction of COVID infection and COVID deaths. So about a week ago, nursing homes in Maryland and across the country received their first check, and it was about $20,000 per nursing home. I can actually send you, and I know you as a scholar will appreciate this, the formula that CMS used. It's several pages long, but it's interesting discussing that on HGO as a matter of public policy, because the formula essentially added the likelihood that states that have had a summer outbreak, our major first outbreak was March and April. So those states that were red in the summer actually statistically benefited by having more states in the West, Arizona, Nevada. They got more payments under that formula because they were more hot now and hotter, more hot and hotter now with COVID. So that's the value-based program for 4 months, September through December, $500 million a month. Now, here's the interesting thing, one small aside. There was also about $250 million that were set aside for something that I mentioned before, the Echo Hub project, if you write that down, the Echo Hub project out of the University of New Mexico. It's a 16-week cohort program where hospitals partner with nursing homes on infectious disease protocols. And in Maryland, we have 2 hubs. We have one convened by MedStar and one convened by Johns Hopkins. And so starting actually this week, so for the next 16 weeks, Johns Hopkins infectious disease protocol people will meet with their nursing home counterparts every week virtually. And MedStar will meet with theirs virtually. And by the way, the massive whopping dollar amount that nursing homes can receive for that is $6,000.
Over the 16 weeks?
Yes, ma'am. It's not meant to be really an incentive financially. Yes, there is about a $6,000 stipend.
And
but again, I'm actually really excited about that work, because when you look at the Echo Hub project, again in Maryland, being convened by MedStar and Hopkins, and really covering most of the 227 nursing homes in Maryland. So when you look at that, and when you look at the HSCRC grants to partner hospitals and nursing homes, I'm encouraged by both of those initiatives.
All right. Thank you. I may have some follow-up questions, but I know where to find you guys. Thank you so much, Madam Chair.
Absolutely. I don't see any more questions from the committee. I just wanted to take a moment to thank the industry representatives on behalf of the committee, and please pass on our gratitude to your workforce. We know that it is hard, often thankless work, often for low wages. We know that workforce is out there, risking their own health and safety to take care of people who are vulnerable and in need. And we really appreciate the work that they're doing and continue to do. So thank you very much. And let's move on to hear from Peggy Funk, who is the Executive Director of the Hospice and Palliative Care Network.
I think I'm unmuted now. Okay, well, good afternoon, Madam Chairman and members of the subcommittee. And just for the record, my name is Peggy Funk. I'm the Executive Director for the Hospice and Palliative Care Network of Maryland. I appreciate the opportunity to be here with you today to be able to give you this update on the state of hospice and how we've been doing during this pandemic. Just want to start by giving you some background on hospice in the state. So for the year 2019, hospice providers served 24,958 Medicare beneficiaries in Maryland for a total of 1,566,905 days. 53% of those beneficiaries received care at home, while 44% of patients received hospice in assisted living or nursing home facilities. So for 2020, everything has changed. In August, the network submitted a letter to both our legislators and the Maryland Healthcare Commission, which is why I believe I was asked to come here today to update you. And in that letter, in which 18 of our hospice member providers signed on to, the network shared what the current environment looks like for our members today. The pandemic has caused challenges for hospice providers, as it has for all healthcare providers. And our members, like all healthcare providers, have risen and adapted to the challenges, like the heroes they are. Just 2 weeks ago, the network surveyed members to get an update of what the current environment looks like for them now. We found that there are 4 areas that continue to serve as barriers in caring for patients, very similar to what we've just heard. The 4 areas fall under access to patients, PPE, testing, and staffing. The first area has been the challenge of getting access to patients in assisted living facilities and nursing homes. This being said, I just want to stop here and emphasize that hospice providers value the relationships that we have with the ALFs and SNFs. We do continue collaborative efforts with them and dialogue. We also understand the pressures they face and that they really have done a good job. However, hospice does have concerns that patients and families are not able to fully utilize the hospice benefit. And so we did a survey, and I just want to share the results with it. So as far as access to care, what our members are reporting is that the rules allowing hospice team members to visit patients just seem to vary from facility to facility, and they can change from shift to shift. We understand that, this is to protect patients. We get that, but still that is a barrier for really giving good end-of-life care. There's also the change in regulations that complicate patient care. Weekly testing is required of hospice staff with no funding to cover the cost. Patients are being referred to hospice much later, or sadly, in some cases, not at all, resulting in a decrease in the length of time patients and families are able to receive the full benefit. While telehealth has been a helpful option, we have found that facilities who are not allowing hospice visits have insufficient tools or staff to assist with this option. The second area of concern that we asked about in our survey was PPE. And we agree that this has gotten a little bit better, but still our members are commenting that it seems as though smaller hospice members and those who are not connected with a hospital system are still struggling with getting more PPE. And that's a big concern, especially with COVID ramping up over the past few weeks. Suppliers have also placed caps on the amounts of PPE our members can order. There have been delays in orders. Items that typically would take that would typically take 1 day to get in stock are now taking a week and in some cases months to get in stock. So that is an issue for us. And then there are the increases in prices that have occurred during the pandemic that are just crashing budgets. The third area that we asked our members about and they commented on was testing. So testing lag times do present barriers to patient visits, and this is a financial hardship for hospices as well. Again, hospices who are connected with a hospital seem to fare much better in this area. The other thing is it's very difficult for members to get a testing schedule. because the labs are just so busy. So again, visits are delayed. Testing is proving again to be a financial hardship on hospice providers, as all members of their team need to be tested. And that includes the full interdisciplinary team of hospice that go in to visit. As far as staffing issues go, we did ask about staffing issues as well. And again, they made the following comments. Parents are working less hours because they need to be home to take care of children as well as school them. Sons and daughters are working less hours to take care of an elder for whom they are concerned about bringing in an outsider. Hospice inpatient staffing has been a challenge. Everyone seems to be recruiting. We know this, we just talked about it. The current nursing shortage has contributed to everyone just trying to hire nurses. And again, I think that was touched on a little earlier. So the other comment that they made was that hiring qualified, competent, and caring certified nursing assistants and certified medication technicians has been challenging during this time. Though not directly addressed in the survey, I would be remiss if I did not mention the increased need for bereavement and grief care. Bereavement care is a core part of the hospice benefit, and our hospice chaplains, social workers, and bereavement professionals have been working diligently to address these needs in the community with enhanced programs. They have additional check-in calls and innovative online and virtual bereavement programs. These programs require additional staff and resources to assist our hospices in supporting their communities. My last comment, and one that was mentioned in our letter, is that our members are most of all asking for a balance in initiating any new regulations regarding hospice so that our members can continue to focus on patient-centered care while this pandemic continues. And with that, I'd just like to say I appreciate your support. And if anyone has any questions, I'll be happy to take them.
Do we have any questions from members of the committee? I don't see anything in the chat box. While people type if they have a chance, let me just ask my question, which is, we're just talking about the bereavement and grief care. And I'm wondering if you could just expand on that a little bit. I know I have been to many too many Zoom funerals over the last few months. I know most of us have. Can you talk about sort of how you've adapted in this context for that type of work?
Sure. So a lot of our members have ramped up just the time that they spend with families. So they have started to check in with them a little more. We know that this pandemic has just been devastating on families who have lost loved ones. And, they have not had the opportunities to grieve. In many instances, they've not even been able to have a funeral. I will tell you a personal story that my own dad died in May, not of COVID. He was at home in hospice, thank heaven. But it was very difficult on the family. We could not hold a funeral. It was very limited, in what we could do for him. Other things that hospices have done is they have developed virtual bereavement programs, which do seem to be working fairly well, although nothing could possibly take the place for a face-to-face, counseling session, but, they do the best they can. So it's the check-ins, it's the additional virtual programs. They're doing, of course, using all of the options, the technology that's available to them.
Thank you. And we do have questions from the committee. Sure. Delegate Lewis, then Delegate Krebs. Delegate Lewis?
Whoops. Thank you. Thank you, Madam Chair. Thank you so much for your presentation, Ms. Funk. I was struck by your remark about the cost of PPE. And I seem to recall that when we passed the authorization for the emergency response back in March, I must have been dreaming. I thought we prohibited price gouging during the pandemic. And I just wondered if you could say a little bit more about that. Have you experienced what you might call price gouging in the cost of PPE?
So Delegate Lewis, I have not. I don't know that it's so much the price gouging, though I think that is certainly possible. I think what it is, though, is that the increase in PPE that is required for hospice to be able to make visits. And, you know, I think that is seen across the spectrum of healthcare in general. So I think, you know, that's what it is. You have a budget and then all of a sudden you're required to have, you know, 10 times more PPE than you had budgeted for. That is an issue. And then of course, I want to say too, it's also the scarcity of PPE because it has been sort of rationed. And, you know, our hospice providers are struggling with that.
Is there anything the state can or should think of doing to ease that burden? I mean, you've got to keep staff and patients safe from transmission. A shortage of PPE sounds like a really intolerable situation. Is there, what could we do that would make that easier?
Mm-hmm. Well, thank you for that. I really appreciate that offer, and I'd love to see more dialogue on that point. I'm trying to think. For now, I think what I would like to do is, you know, perhaps again, just more dialogue. We could identify those members who are struggling the most and try to get them some relief.
Mm-hmm.
I think what I wanted to say was that hospice hasn't necessarily been included in a lot of the conversations on PPE. So we would appreciate maybe a little bit more inclusion in this area.
Great, thank you so much. And thanks again for all you do.
Thank you.
Delegate Krebs.
Thank you, Madam Chairwoman. You started off by talking about the barriers to caring for patients and the access to patients in long-term care. And maybe Joe or Donna can help with that. But I know in our hospice, we'd had trouble early on and still now in certain facilities. And that concerns me, especially now. So who decides who can utilize the hospice benefit with having the hospice people go in to the facilities? Who decides that? And is there any parameters that are set for that? Either Donna or Joe or Peggy. I mean, I know from our perspective, it's been very random among the nursing facilities and assisted livings. They have their own policies, but it's like denying access to a doctor to go see their patient. It's a hospice provider. I don't know.
Yeah, I'll chime in and then tag team it with Dana. First, I'm really sorry for Peggy's loss. And I'm thinking a lot about my dad, who had great hospice 8 years ago. And I thought of him because it was paid for by the Veterans Administration. And yesterday was Veterans Day. And it was a godsend, the hospice care my dad got. This is one where we have learnings. I don't think we're doing our best work on the integration of hospice and nursing homes. I just don't think we are. And I think that it's because we don't have a standard statewide approach. And that's been, the problem in this pandemic, just in general, right? That many of the government state orders are left to the interpretation of county governments. So I've seen nursing homes who have done hospice and bereavement visits and do them really well. And then I've seen some who I wished would have done better if it was my mom or dad, right? So we got to do better on that. This is a learning that I want to be transparent about. And so yeah, we got to do better. Dana, what would you say?
Well, I just want to ask you what rights the patients or their families have if a specific facility, and I mean, some of these people are trying to be so cautious and careful about denying access because they really are being careful. But what does the patient have to say? No, I need to have access to my
Well,
hospital.
listen, I've worked on a couple of these cases, like personally, right? So I give you a case. So we had an assisted living, a really highly regarded assisted living, and they were very cautious and they were following the rules of SNFs. And they had a couple and the one, I think it was the male was dying and on his last days, and they were doing visits that were done clinically appropriate with the proper PPE and the proper supervision. And then they had an outbreak at that center and the visits were canceled. And like, we're like, you can't cancel the visits. Like we called people and advocated and said, look, you can't do this. I think most centers, so first of all, people have the right to even under the governor's orders, they have a right to go and do a visit that is essential for their care. And we've worked on those too. Let's say somebody who's not a hospice patient, but in a nursing home and will only eat with their family member there, right? So we've had situations like that where we had to get a family there, even with bands and with proper PPE to do that. And we have had situations, if somebody is dying and on hospice, there are accommodations for them to go. Here's the thing, testing and cautious approaches have sometimes stood in the way of that, and trying to have a broader spread or how bad the outbreak is in the center. So it's
well, the reason I'm asking, we've actually have people that are pulling their loved one out of the facilities and taking them home because they can't be with them. And listen, Peggy, my dad died in June very unexpectedly, and he was in hospice care at our Dove House. It was the most unbelievably wonderful experience for our family because we were able to be there.
Right.
But I've dealt with so many people over the last few months that did not have access to their loved one. And it's bad enough to be in a hospital for weeks or days or months or whatever, and not be able to see your loved one. But then to go to a facility and not be able to see them and then pass away, I mean, there is no closure for anyone. And it's just, so I just would like to make sure that these facilities know that people should be able to have access, and especially at end of life like that, everyone should have access to their family in a facility. I know they want to keep things, I mean, some of these facilities have had no outbreaks at all, and they're just trying to keep it that way. But you got to remember the patient that's there, this is their life. This is their family's life. So it's got to be balanced. There's got to be some rights to the patients and to the families. So
I agree 110%. The other accommodation is we have to make sure that the Office of Healthcare Quality doesn't cite a nursing home in that instance for the access.
And I don't know if they would or not, but you're right about that. They're very cautious. But thank you very much. That's a very big issue, making sure that there's no barriers to the hospice care. Thank you.
Thank you.
All right, I don't see any more questions from the committee. I did want to take a chance to follow up if Dana's still here. I know Delegate Lewis's question about price gouging and PPE. I know I've heard you speak in the past about this being a cost that the industry had seen, and now we've seen prices come down a little bit. Did you want to add anything?
Sure. And I think in the beginning, so one, you are correct, Delegate Lewis, in the bill that you passed, there was a provision prohibiting price gouging. But I think what occurred in the beginning was just basic economics. There was a scarcity of PPE, so the prices just skyrocketed. Whether or not those prices could have been litigated under price gouging, I don't know. But the good news is we have seen those prices coming down. I think we have to be very diligent that with the increased demand, we don't see artificial prices increase artificially. So I think that is something that we really have to keep an eye on, and just keep an eye on what the supply is. Again, I mentioned that the governor had allocated, I think it was $10 million to local companies for that supply. I think that was a great thing to do, because the more PPE we can have within our own state borders, the better, where we're not relying on outside companies. So again, I think this is just one of those issues we really have to be diligent on to make sure that the supply can remains, but more importantly, that the prices don't rise artificially.
Madam Chair, one quick 30-second add-on to that. One thing that is really appropriate for, I think, for all of us and this subcommittee and HGO is to look at price gouging on medical staffing companies going forward. It's been an absolutely huge issue. And I, for one, want to understand that if a temporary medical staffing company is charging $200 for a nurse, I want to know how much of that is going to the nurse and how much of that is going to the staffing company. It has been a huge problem in this pandemic.
Thank you for that. We will keep an eye on that. It's interesting to think about. Thank you to all of the panelists today. Really wonderful discussion. Thank you to the members of the subcommittee for your great questions as well. And definitely thank you to the staff who have been helping us run this meeting. Very, very much appreciated. I have a few closing remarks. The legislature's COVID-19 response work group will continue to address a variety of issues related to the topics and jurisdiction of this and other committees. As of now, at the direction of the work group, HGO has scheduled a series of full committee and subcommittee briefings for the public. Please monitor the HGO committee hearing schedule on the Maryland General Assembly website for updates. For committee members, you've previously received a list of meetings and dates via email from committee staff and will continue to receive updates as necessary. The next meeting on our schedule will take place on Tuesday, November 17th at 1 p.m. On that date, the full Health and Government Operations Committee will receive updates regarding hospital systems in Maryland. We'll hear about current financial assistance and medical debt collection policies and receive a briefing from the Maryland Department of Health regarding Optum. We will be joined by members of the House Appropriations, Health and Social Services Subcommittee. We look forward to seeing everyone there. I would like to thank everyone and have a great afternoon. Bye.